Hello, I'm Dr. Prashant Vaz, a research registrar at Ipswich, and I'm presenting on behalf of the Ipswich Diabetes Research Unit our innovation, which is the Ipswich Touch Test, and reducing the incidence of diabetes-related foot ulcerations in hospital using the touch test and the foot at the end of the bed tool. The NHS Innovation Expo gives us a forum to demonstrate our work to a very focused audience who can then take this and adapt it to their local population. It highlights our work, it gives it important publicity, and I think that those are the important things for us to bring our work over here to NHS Expo. Importantly, like I said, a lot of people are doing very interesting work. We don't have to reinvent the wheel a lot of the time, just adapt our ideas. Clearly, our work was based on reducing the incidence of hospital-acquired foot ulceration in people with diabetes coming into hospital, and we have shown a continuing improvement in decrease of foot ulcerations. Indeed, when we last analysed our data, the incidence of foot ulceration in Ipswich Hospital had decreased by 73% compared to baseline values of 2009. And this is very fascinating that a simple method such as ours could show such powerful improvements in outcomes.
I'm presenting this on behalf of Dr. Jerry Raymond, who is the National Inpatient Lead for Diabetes Buddies at Manchester. And together we came up with the Ipswich Touch Test and the foot of the bed form. And really these are very simple tools to improve and increase foot examinations and try and prevent hospital-acquired foot ulceration in people with diabetes. You expect people to come into hospital with diabetes to be examined, but in a busy day-to-day sort of work environment, it doesn't get done, and which is why we came up with this. And the background to this is about 15% of everyone in hospital has diabetes. Indeed, in some parts of London, this is higher. And sadly, 1 in 30 of hospital beds are acquired by those with some sort of diabetic foot disease. And most of it is preventable. You detect those at risk and then make sure it doesn't happen during the hospital stay. But from the national data that we have, the audits that we do every year, only about a quarter of those coming into hospital have foot exams. And that number, although has been rising, has never gone beyond 50%. So 1 in 2 still don't get examined. And this is not because of shortness or shortage of guidance. The NICE document exists. There's a joint document by various clinical societies saying that we need to put feet first, get people with diabetes assessed for the risk of getting a foot ulcer while in hospital. So it's not because of the lack of guidance. There's many barriers, some of which I'll touch in. We do have a busy schedule in life. We find ourselves sort of rushing from one job to the other, quite difficult to get everything done when they come through the front door. And if you use an equipment to test for neuropathy, which is what leads to these ulcers, it's difficult finding equipment to use. I mean, if you go to the ward and try and find a simple thing like a pen torch to look in someone's mouth, you will have to go and ask 10 or 15 people. You won't just find it. And if you start keeping equipment there to detect neuropathy, it'll go missing. Little things like this, you will test someone, put it in your pocket, walk away, and the next person won't find where it is. And it's also important to involve the right staff. I mean, you can get the doctors to sort of write in the notes, and it gets in the notes and then doesn't get handed over, because we don't communicate as well as we should. So maybe we're not the right people to be involved in detecting this sort of part of the ulceration. And it's the nurses and the healthcare assistants who actually change the patient, talk to the patient. They are there on the ward every day. They see things going wrong. If they're aware that someone's at risk, they're probably best placed to institute any intervention if it's required. So to detect at-risk feet, we need a test that any member of the healthcare team can do with little training. So really, we need a test, or we needed a test that was easy to perform, which was rapid, reliable, safe, and we didn't want any equipment because we didn't want anything to go missing from the wards. And in these cash-strapped times, we wanted an inexpensive method. So we came up with the Ipswich touch test, which simply involved using the index finger and lightly touching these 3 sites on each toes, the first, third, and fifth. And if you couldn't feel more than 2, then really there's something wrong. You probably, if you stay in a hospital bed for too long, you'll end up getting a foot ulcer. And the data comes from other studies looking at people who are insensitive to their feet developing foot ulcers in the community over a period of time. We would like to have called it the touch test. We didn't want to put the Ipswich name, but the Americans have beaten us to trademark something called the touch test, which actually are monofilaments, which they use in America. So that is why we ended up calling it the Ipswich touch test. So initially we validated the test in 3 hospitals, at Ipswich, at Norfolk and Norwich Hospital, and at Royal Devon and Exeter Hospital. We used about 265 subjects, and we compared our Ipswich the touch test method against both the monofilament, which is a standard use in the community, and against vibration perception thresholds, which are used as research parameters. And if you can't feel vibrations when applied at 25 volts, you're about 8 times more likely to get a foot ulcer. So we use that as a gold standard, and we compared the 2 methods, the one that's used commonly, the monofilament, and our touch test method. And really, there's not much of a difference between the 2, at least clinically. The monofilament marginally performed better, but in a clinical perspective and for what we wanted to aim, we were pretty happy that the touch test was good enough. So it was a easy to perform and teach method, rapid, reliable, safe and sterile. And because it was so simple, all you had to touch is, touch 6 toes. Any member of the healthcare team could do it. The challenge from there on was to implement this in different wards. Remember, the hospital environment has different wards, different focuses. The oncology ward has a different focus to the gastroenterology ward, which has a different focus to the orthopedic ward. So we used a phased rollout method. We took 2 wards at a time, got the staff in to come and meet us during their lunch break, and rolled it out and trained them over a 30-minute period. We gave them a patient story. I had a video for it, which I'll show you downline. And when we asked them, once you've learnt it, go back and train the other staff who haven't been able to attend these training sessions. And we kept on going back to these wards and auditing and re-auditing and re-auditing to make sure that once they have taken up the process, that they were keeping it up, that there wasn't this enthusiasm for a month and then everything went downhill after that. So I've got a video. This is the video which we used to sort of roll out the program. And actually, this is a real patient that we saw in the foot clinic after he had stayed in hospital for about 6 weeks. There is a patient carer also in the video, but it's pretty powerful, the video, which highlights the problem of people coming to hospital with diabetes, running into trouble because of complications. And then these don't go away very easily.
So hello, Mr. Hart. Your GP referred you back up to us. You've been discharged from the hospital, and I understand you've got an ulcer on your heel now. Tell me, how did this happen?
Well, I was in hospital in 3 different wards, and after the first week in the ward, I complained my heels were getting sore, and they just, didn't do anything about it.
They must have put something on to protect it.
Nothing, not a thing.
Tell me, has anyone ever told you that you had a problem with your feet?
Nope.
So, how do you feel about this?
Well, I'm niggled, but why I'm doing this is to help other people don't go through what I've been through.
What I'd like to demonstrate, and this is helpful for you to understand, I'll show you a very simple test which will show us that Mr. Hart can't feel well and that he is at risk. Mr. Hart, I've just touched you on the hand, and you can feel that. I'm now going to touch you on the feet, and you tell me, say yes if you can feel a touch.
I shut.
Yes, I shut. And you can see that he has lost sensation. That leaves him at great risk of developing a heel ulcer in hospital. And that very simple test we should have done on every single patient who comes in with diabetes. And if you find a patient who can't feel, they need special offloading protection to make sure that they don't develop a heel ulcer.
So this is the foot of the bed form that we use in the end. So even if you don't have an ulcer, we expected the team on the ward to document their daily findings. And this is a useful tool for us to know people have checked feet, that the socks have been taken out every day. And it just gives everyone a guide to what needs to be done next. A lot of the time, just because a lot of attention has been given to patients, they don't get the foot ulcer or the complications. And if one of the main aims of the project was just to make sure people actually do that, take shoes and socks off, have a look at it, that would give you most of the information in the first place. This is a good way to follow a protocol, get it down, and hospitals these days are also marked on whether or not foot examinations are carried on. So it's quite a powerful tool for that goal. We were quite intrigued and a bit worried to begin with to see if all the wards would take this up. It would be additional work, even if it's 1 or 2 minutes, still add to the workload. So we started to audit the wards, go back and feedback about what they were doing, encourage them to continue doing what they were doing. And over a period of about 14 months, we started seeing that we had about 80 to 90% uptake consistently. Somewhere after 5 months, it flattened off between 85%. And we were quite happy that all our hospital wards were being engaged. When we had done the video, we were down to 60% reduction. But when we analyzed the up-to-date data, we managed to reduce the foot lesion incidence by about 73% now, because we get going back in, day out, reminding people that the wards need to be looking after feet, and using a simple method like the foot of the at the end form and the touch test. We're getting pretty powerful data to show we can actually reduce the number of complications from the foot for people with diabetes coming into hospital. And this now initiative is being taken over by NHS Diabetes and Sanofi Diabetes, and the plan is to try and roll this out to about 67 trusts who have expressed an interest. But the other thing was that in a primary care environment, not hospital environment, when Diabetes UK did a survey a couple of years ago, came to their light that up to 1 in 4 people did not recall having a foot examination. We know from the GP cough data that about 90-95% people are having foot examinations, but people can't recall having them. And even if they recall, they didn't know where they stood. Was I high risk? Was I low risk? Because a lot of things get done, a battery of tests get done when you go there for your annual assessments. And we wondered whether we could use the touch test to empower patients, get them to do it or their relatives to do it at home. And that would provide them with immediate feedback as to whether they were at risk or not. And would also get them to examine their feet more consistently, because we keep on asking them in the clinics, go examine your feet on a regular basis. But if they knew they were going to be at high risk, and if you could use this test to empower them, it would make a huge amount of difference to them developing foot problems at home. So we came up with the idea of screening for diabetes neuropathy at home, which we call the home Ipswich touch test. And for all the patients we were due to review in clinic for about 6 months, we sent them a piece of an information sheet inviting them and their relatives to do the Ipswich touch test at home. And when they came back to clinic for their review, we compared to what their relatives did to what we could do with the touch test and with the monofilaments. And interestingly, the relatives were as good doing the touch test as we were. Because it's such a simple method, you didn't need to be trained up. And the data we have from when we collected it was done through lots of the healthcare professionals, the HCAs, the healthcare assistants anyway. And we were not quite surprised to see this, but it was, again, very encouraging to know that. And the feedback we got from that was that about 90% thought that the instructions were clear in the leaflet we sent them out. And that, again, 90% thought it was easy to perform. But more importantly, almost 97% of patients thought their awareness of their feet improved. And this is very powerful again, that they be more aware, which means they look after their feet, they look out for any problems down the line. And again, relatives didn't mind doing the test on their loved ones. This test has now been taken over by Diabetes UK. And now Diabetes UK has come up with this program where patients are encouraged to do the touch test at home, get the relatives to do it, and hopefully this is going to help prevent de novo foot ulcers happening in the community, because when you know you've got a problem, you'll watch out for it. Prevention. Molly Donoghue, who collaborated with us from Exeter, took a sabbatical to India, and she used this touch test over there to see if she could help the more resource-poor environments detect neuropathy. And she took some monofilaments, did the touch test, and compared the monofilament to the touch test, and they found that if you took the monofilaments as the gold standard, the sensitivity of the touch test was nearly similar. And we're doing more studies now in Grenada with the Minister of Health of Grenada. So in summary, the Ipswich touch test is a simple, easily taught method for detecting at-risk feet. And it can be used in hospital settings to screen those at risk so that we can institute preventative measures immediately and effectively. And it's very simple. And because of the simplicity, it is manageable to sustain a high uptake of this method. And furthermore, it could be used by patients and their relatives to self-screen themselves, and has a great potential to detect neuropathy in resource-poor environments. So I would like to thank all the trusts that collaborated with us, all our patients that collaborated with us, the podiatrists from both the hospital and the community, and Dr. Sharma is continuing to do more work on this at Ipswich, Diabetes UK for their support, and HSJ for their recognition. Thank you very much. If you have any questions, I'll be happy to answer them. And if you want any more information, feel free to contact us at Ipswich. We will always be happy to guide things if necessary. Thank you.
I think we have 2 or 3 hopes. The most important is to try and get the Ipswich Touch Test rolled out to as many trusts across the country, so that we can try and decrease the spectre of diabetic foot disease acquired whilst in hospital. Clearly, it's preventable, and this is a very useful tool. Secondly, we think it's a great tool to self-inform patients, get their relatives to do this at home. And when someone's done a test and they realize they're at risk, they would never forget it. And it's far more a greater an advice than in a very chaotic clinic informing the patients along with the other battery of test results that perhaps their foot are at risk. So that's one of our other objectives. And thirdly, we are trying to do studies to see if the touch test could be a useful tool to detect at-risk feet in resource-poor environments. But perhaps we need to do more work on that down the line.